I've been in all of those roles that Bob was mentioning about. I'm in private practice in Fort Myers. I'm a board-certified child psychiatrist. I'm also part of the faculty at USF, and I'm also overseeing the children's Medicaid services under Magellan for the state of Florida. So I've had several roles that really have challenged, as a practitioner, what I have to do with my patients and really start to think about what's really going on. And in the ideal world, everything I'm going to try to tell you in a short period of time would be doable, but really it is not. As you know, in the ideal world, seeing kids and evaluating children and families is very time-consuming. It's certainly not a money maker, but it's very essential. It's very important because in the long run, we're all paying for the patients that are very young that are not getting treated. And over again, we think that there are many instances in which there is generational effects. There is all kinds of effects that are going on with the severity of kids that are presenting today. The guidelines, as were reviewed a few months ago, were interesting because a lot of the experts all throughout that came in and talked to the local physicians here in Florida were basically saying some of the things that we're doing, and a lot of what we're doing is off-label, and again, we are trying sometimes to do something that is in the frontiers of treatment. It's not really evidence-based sometimes, and there's very few studies to support it. So for example, if we looked at bipolar disorder, double-blind placebo-controlled studies on bipolar treatment in children, there may be 8, and there's very few examples, again, in many other areas. This is the guideline that came out last year, the first time, and it's been around. This is something that's really useful. I use it in my practice, in private practice, and I've used it when I talk to other physicians, especially primary care, because it gives you a very quick look at levels of what you do first. And notice that what you do first is what we were trained in medical school or in our schooling is you really need a good history. You really need to take a real good history because there's so many things going on that we don't know about until we ask. And then when it comes to children, you need to get a good history from different informants. You definitely need to get a history of what's going on at school, what's going on at home, what's going on with multiple caregivers. So getting a history is very important. You can't take a shortcut with that. And more and more are children that are being referred for developmental disorders, for autism, for Asperger's, at a very young age. So you're getting preschoolers that are being screened in the school or in the community, then eventually they're referred to specialty clinics or pediatric practices, or then eventually subspecialists like myself in pediatric psychiatry. So by the time I see the children, there's been a whole range of tests that have been done, usually a psychological battery of tests. But still I find that there are times that kids are not being tested specifically for their age group, or there may be some baseline developmental tests that haven't been done. For example, yesterday I had a case in which the child was diagnosed autistic, but the tests that they did, and the child definitely has some cardinal signs of autism by the history, but they never have done a Vineland, and what they did was an Asperger's screening test. So sometimes we really need to go back and really document the baseline and do the full evaluation, because as we follow progress of treatment, that's the only way we're going to be able to follow what's going on with the children. So I really emphasize that when you're doing an evaluation, to really, if it's been done, to get those records and make them part of your full assessment. Let's go ahead and move on here. And by the way, there are many of these scales that are recommended. More and more in research and in university settings, these scales are commonplace. They're used. But in private practice, they're not really used. but we're going to be forced to use them more and more. Some of them are in public domain, so for example, the Strengths and Difficulties questionnaire, the childhood behavioral checklist, Connors. There's many that are being used. In fact, there are school systems that are now buying some of the questionnaires to help with screening patients before they're sent back to the primary care for further testing. And I think that in your practice or in your facilities, you really should start to try to use some of these, because this is how we're going to follow evidence-based symptomatology, which will help with diagnosing and treatment. But again, we're talking about very young children, so making a diagnosis becomes very difficult. So making an assessment of the symptoms and the severity of them may be the best that we can get in the ideal world now. And then later, we may be able to find more opportunities to test children in ways that we can really get a sense of what the true diagnosis is even earlier. This is talking about, again, psychotropic medications use really after the evaluation, which I said is so important that you get a good history from many informants. The way to go is really the treatment of choice is not medication. The treatment of choice really is interventions based on the needs of that child and that family. So many times, even though I'm a child psychiatrist, there are many individuals that I see in the community or that I supervised under Magellan that I'm always asking about the therapies. What kind of therapy has been done? Is it cognitive behavioral therapy? What is the play therapy? Because we hear a lot about play therapy. And what is really the management of the parenting, psychosocial parenting skills that are in place, or what are we doing about enhancing the parents' management of these difficult children? So the psychosocial treatment is a must, and that's a standard of care. And so when we look at the guidelines really are based on the standard of care throughout nationwide, and many of these guidelines are based on guidelines like the ACAP or the APA. So many of the guidelines are a subset, and what we're trying to do in Florida is be more proactive and keep them current and disperse the information so everybody can be on the same page. But so really the treatment needs to be documented, and what type of therapy. Many times I have parents that have come in that have said, oh, we've done that, and when you go a little bit further and peel away the layers, you really find that they haven't done that, whether it's using the 1, 2, 3 magic or using any other kind of interventions. That therapy is really not therapy, and that you really have to get down to the nitty-gritty and find out what kind of interventions have been done in school and at home. And document that psychosocial interventions have been done, because again, we're talking about a very young age group, and many of the treatments, when we're talking about the medication treatments, are not FDA approved. They are off-label, so you really have to do a lot of documentation that other interventions have been made, such as behavioral therapies and other psychosocial interventions. And then monitoring these. Now, the simplest one I can think of that I monitor would be, for example, if I'm using CBT, which I do CBT on OCD patients, whether I have medication on board or not. If I'm using CBT, I may do the YBAC, the Yale-Brown obsessive-compulsive scale. If you're treating for ADHD, you may use a Connors scale. But you really need to have some kind of ongoing monitoring to see the treatment. When we look a little bit further at the next step, which is we did the evaluation, we looked at making sure that psychosocial treatments or other treatments were tried. The next step, of course, is to consider medications. And again, in this area, it's off-label. There's very few studies. And what you're doing is you're trying what you feel comfortable with, and what you think and you've been exposed to in your training, in your experience, that works best. But really it's like when we talk about geriatric population. You start low and you go slow. And you go very, very, very low and slow, even though at the end, milligram per day, you may end up